We shall now go on to our next speaker, Dr. Praveen Dhanapal, who is the Director of the Cornea and External Eye Diseases and Refractive Surgical Services at Ratan Jyoti Netralaya, Gwalior. I should have had Dr. Purendra Bhasin as one more expert panel when I had you here. So let's look at his interesting set of videos. On to you, Dr. Praveen.
Sure. A very good evening to all of you. I'm sharing my screen, ma'am.
Yeah.
Can you see, ma'am?
No.
Yeah.
Yes, yes.
So this was another routine cataract surgery for me. A nice access was done. Anterior chamber is filled with the viscoelastic. And now when I'm injecting the IOL, you can see the haptic is already partly outside because it was loaded by my assistant. I thought, no, this is not the right way. So I reloaded the IOL and now I'm injecting the IOL. So the leading haptic and the optic goes out very nicely. But notice the trailing haptic. It gets detached from the optic. So now I'm planning to bring out the optic out of the bag gently using the Sinski hook. It's out now. I am holding the optic using the grasper. Since the haptic was intact, I'm trying to reattach the same haptic here. And IOL is completely horizontal. You can see the optic is attached and forming the anterior chamber again with the OVD and gently reinserting the IOL into the bag. See, IOL is centered well now and OVD is removed. Surgery was uneventful and post-operatively patient was 6'6". And this is another case, a 67-year-old gentleman, aphakia post-VR surgery. He had undergone scleral fixated IOL, that is Yamane technique, in 2019. And post-op, he maintained best corrected visual acuity of 6'6". And 2 years later, he presented with endophthalmitis. And visual was PR accurate. We can see here inferiorly, the flange of the optic has eroded the conjunctiva. And this is the source of endophthalmitis. There's hypopyon in the anterior chamber and his IOP was 56 earlier. So we gave intravitreal vanco, septa and deca after managing the IOP. Now the next plan of management is explantation of this IOL with repeat intravitreal vanco, septa and deca. But the problem is exposed irregular flange which is eroding the conjunctiva. And we thought, why not address this issue? So now I'm holding the flange and slightly trying to exteriorize it, pulling it out gently with the microforceps. I'm trimming the irregular flange and recreating the flange using the Bowie cautery. The idea is to have a smooth and round flange here. And the flange is again tucked inside. Making the paracentesis incision and washing the anterior chamber of the exudates. Anterior chamber is formed and I'm again giving intravitreal antibiotics and steroids. And this is at 1 week follow-up. We can see the haptic is nicely fixated into the sclera and patient has got good visual acuity, and this is at 1 month post-op. Best corrected visual acuity is 6'6" again. The haptic is now fixated into the sclera. This is my third and last case. This was again disenclaved iris claw intraocular lens. The surgery was done around more than 30 years ago. And we can see a large ECC wound with multiple stainless steel sutures here. His best corrected visual acuity was 6.9 and the specular counts were good. So our plan was to again re-enclavate the same IOL, making the paracentesis incision and trying to assess the location or the enclavation part, site of re-enclavation, doing limited anterior vitrectomy. Now I'm holding the IOL with the micro grasper, and with another micro rhexis forceps, I'm re-enclavating into the iris. Antechamber is washed off the on viscoelastics, and case is reformed. This is post-operative day 1. We can see well-centered IOL, and this is at 1 month post-op. The patient regained 6/6 vision. Thank you.
Thank you very much, Dr. Praveen. That was a wonderful set of videos, and I felt very happy to watch them when I did. Now, some questions related to this, Dr. Rohit and Dr. Gaurav. How often have you tried inserting the haptic and you felt that it remained safe and fine and it was placed in the sulcus? And what is the way you can avoid this haptic erosion from happening if it has happened primarily? The way he managed it was fine, but the primary way how to deal with it, Dr. Gaurav?
Ma'am, I wanted to ask because maybe I missed a few seconds of the thing was how that patient presented with this, but what was the primary treatment which was done for the patient when this happened?
He cut the haptic.
No, I saw that how it was managed, but I was
Yeah.
wondering that how the haptic found its way there, and what was was it a Yamane which was done, and then
Yes.
after that?
Yes, sir. It was a Yamane.
Also, it was a post Yamane.
Post Yamane only.
So the tunnel was already there, and
yeah.
Right. So typically, I think if you've marked your, the exact 180 degrees and your, the tunnels, the direction of the tunnel and the length of the tunnel is adequate.
Yeah.
And also the choice of lens, frankly, because, if you have a IOL which has very long haptics, you may have to actually kind of trim them. Otherwise, they will produce a pressure and they will kind of, extrude like this. So the choice of IOL and all these things will go into ensuring that you've been able to kind of, prevent this kind of a thing. Yet it will still happen sometimes. And, I was happy to see that it was managed and it worked, because I would have expected sometimes to have, probably because you shortened the haptic as well. And that may have been the reason for, that extrusion. And once you shortened it and then you kind of treated it nicely with the cautery and, may have pushed it back. So it stayed there, but I was concerned that again, it might not just, happen one more time. And then the conjunctiva will not usually heal very well in such cases, because once it has been damaged and that area is now weak. So these few things are all possibilities, ma'am.
But again, in that particular case, which he showed very gracefully, but I wouldn't have enclavated it anteriorly after knowing the endothelial problems which can happen if you do an anterior enclavation. I would have still taken out that lens and done enclavated it posteriorly, iris fixation, retrofixation I would have done. And if it is a retrofixated iris which you want to disenclavate for whatever reason, any tip as to how it could be done? I think my mind says that if you take your spatula and push the optic of the iris behind take it behind the iris and push the optic behind and go in through the side port, and you should be able to disenclavate it. It might be a little tricky, but I think if there's enough viscoelastic in the eye, Dr. Gaurav or
Ma'am, we have a power cut, so I'll just have to. I didn't get it. I was off for a few seconds.
No.
I agree with you when you say that. I would be reluctant to put that haptic back, but he managed it really well. I would have done a specular, and I would probably at 30 years post-op, I would have found the endothelium to be really bad, and I would have probably, done a posterior retrofixated iris claw or something here. Yet, it's if the cornea is great and everything's fine, he managed it really well. So,
So my
but I missed the second part of it.
If you need to disenclavate your iris, retrofixated iris clip lens, how would you do it?
I have done a couple of them because, sometimes while fixating, so I haven't had a big challenge in doing it. I use a dialer to do it or a hydrodissection cannula to do it. And usually it's fairly easy to do it once you know how the, enclavation and disenclavation works. But are you looking for some special pearl which I'm missing?
It's just that I would push the haptic a little, optic, push it little behind, and then
so that
go
you can
with the
demarcate the area, right?
demarc-
Absolutely.
yeah, that's
Just
what
like when you're trying to suture a haptic, which is behind the iris, you just push it up so that
Yeah.
you can kind of see that thing through the iris. It's tenting it up. Here, you would just push it down a little bit so that you can see the exact area of inclination. And then I completely agree with that. That's an important pearl, ma'am.
In this case, his endothelial cell counts were absolutely good, sir, and very healthy.
Great.
So that,
Great. So then, of course,
that made me rethink my decision, and then I re-enclaved the same IOL.
I understand.
Dr.
Dr.
Rohit?
Chitra, can I ask one thing?
Yes. Who's
Yeah.
that?
Rajesh,
Oh, Rajesh. No.
Rajesh, sir.
Rajesh, you have to find yourself buried somewhere. This is the nth time you are ditching me now.
I'm so sorry. Actually, I was having a session again.
I know
That's
that.
why.
I know.
In a physical meeting somewhere.
I know.
So,
You're running all over the-
actually, I just want to ask a couple of things from Dr. Praveen. When I saw that iris claw lens, I mistaken. There was a faint whitish reflex coming from behind of the two margins of the capsule. Were the capsular margin present, Dr. Praveen?
No, sir. No, sir.
Maybe there was a large rent in the initial part for which the iris claw lens. Oh, okay. It was just okay, by mistake then. The second thing I just want to ask that probably the conjunctiva, the tenons was atrophic in the case wherein there was you know, the Yamane technique that was done. In that case, whether the tenons was absolutely atrophic in that area.
Absolutely.
Because when the haptics were again pushed behind, again when the haptics were pushed behind, later on also in the post-op period, I could figure out that there was a little more of the haptic show, that bead that was showing through the conjunctiva.
Yes,
absolutely.
So the risk of, I mean, these patients will, please.
Yes,
these patients will require more meticulous follow-up because the risk of this haptic coming through the conjunctiva again is very high, because some of these cases wherein the tenons is absolutely atrophic, in such a case, such procedures may be a bit risky, but then yes, if you can do it well and follow up the patient more regularly, that will be better.
Yes. So just a few points here, sir. This if, as you noted very nicely, the conjunctiva was almost scarred, and ideally this was not done by me. This was done by one of my colleagues, and this was not the ideal case to do Yamane technique. I would not consider doing Yamane technique where you have scarred conjunctiva. Post VR surgery, 360-degree peritomy was done, and there was a scarring. And second problem was because of the irregular haptic of the IOL. The flange was irregular, and that made it erode very early.
Yes.
Yeah. Yes. I would, one more thing that I would like to do in such a case, maybe we can press the coagulated haptic from top so that it flattens a bit. Rather than keeping an elevated bead-like end, I would flatten the tip by pressing it with an instrument so that it lies flat on the sclera.
Riveting the column.
Agree,
sir. Agree.
Yeah.
Other than all your points,